I'm Dr. Sandra Brown. I'm an ophthalmologist in North Carolina, and I have no financial conflicts of interest. I'd like to talk to you today about on-label, off-label, or no-label. How radical are you as a patient? This video is not a standalone. Please watch on-label, off-label, no-label. How radical is your doctor? So, are you a radical patient? If your doctor prescribes a drug which is approved by the Food and Drug Administration, and you have the same disease that's on the drug label, the synonym for this type of prescribing is on-label. Why might the drug still not work for you? Drugs don't work for everybody. Or, you may be different than the patients that were in the clinical trial in some important way. You may have other confounding conditions or more severe disease. But if you are using an approved drug for an on-label use, it is unlikely to cause you harm. The adverse events are well known through the clinical trials. What if you're using an approved drug but for a disease which is not on the approved drug label? This is known as unapproved use. The synonym is off-label use. Why might this not work? Well, you might be a little bit too far off-label. Or other patients got lucky and you didn't. But will it cause you harm? Probably not. The adverse events are likely to be similar to an approved use, or similar to a drug which is approved for your disease. How about using a drug which has not been approved by the Food and Drug Administration? If this is you, you are definitely radical. The synonym is no label. Why might it fail? Well, do you always believe what the manufacturer says? And will it cause you harm? I have no idea, and neither do you. I can hear you saying, Restasis didn't work for me, and I'm going to explain why this is not a personal failing. And I have had patients tell me this over the years, and they're really apologetic, especially back in the day when Restasis was first released and it was supposed to be a wonder drug. But if you look at the Daily Med listing for Restasis, you will see that only 15% of clinical trial patients actually showed an improvement, and the primary outcome measure was the Schirmer score, which would not be a primary outcome measure for clinical trials of dry eye medications in the present day. So if Restasis didn't work for you, you're part of the 85% for whom Restasis didn't work. This is not your fault. How about if you tell me, Azasite didn't help my blepharitis? Well, this is not a reason to be mad at the FDA. First of all, blepharitis has multiple underlying causes. In some patients, Azasite may treat an underlying cause, but in your case it didn't. Possibly it was still worth a try. The FDA says it works for conjunctivitis, not blepharitis. There's a picture of bacterial conjunctivitis in the lower right-hand corner, and in fact, Azasite is only approved for conjunctivitis due to a few specific bacteria. You need to have sensible expectations of your drugs. I'm talking about legal drugs. On-label drugs don't work for everybody. Off-label drugs may be medically reasonable, but there's no evidence that they will definitely benefit you for your particular off-label condition. However, both on-label and off-label use of an approved drug will typically have predictable adverse events. First of all, to be approved, the drug benefit must substantially outweigh the risks. Also, most but not all off-label use is close enough to share the same adverse events. With off-label use, your adverse events are more uncertain. But if you want to know what your adverse events might be, that FDA-approved product label tells all. And these are the adverse events for Azasite. If you run your eye down that list, you'll get to the bottom, and second up from the bottom is stuffy nose and sinus infection. If this was a bacterial sinus infection, I really seriously doubt that Azasite caused a sinus infection. But typically the adverse events list includes everything that happened to the clinical trial patients while they were using Azasite. So if somebody got a sinus infection, it makes the list, whether or not there was really any causal connection. Let's take a voyage off-label to give you some idea of the difference. Avastin is used intravenously to treat colon cancer. Lucentis is injected inside the eye to treat wet macular degeneration. Both medications are what's known as VEGF inhibitors. They block new blood vessel development in the same way. After Lucentis was approved, some brave guy got the idea to try Avastin for wet macular degeneration. It's much cheaper. It turned out to work as well as Avastin in many patients, and it made Genentech mad because their profit margin on Lucentis was a whole lot higher than on Avastin. I'm not sorry for them. Avastin is definitely what we would call an off-label drug. How do you get from the colon to the eye? Well, you do. But it's a totally different disease and a totally different route of administration. So was that first doctor out of his mind? No, although, as I mentioned, he was bold. If someone had injected Avastin before Lucentis was approved, would this doc be out of his mind? Yes, he would. But you might say, hey, I think it makes sense. VEGF inhibitors block new blood vessels. Wet macular degeneration is a disease of new blood vessels, so why not just try it? Okay, but start with rats, not grandma, because you have no clue about the adverse events. It might kill every blood vessel inside your eyeball and melt it. If you're talking about swapping drugs, when is off-label pretty safe? First, the purity of both drugs is known, and Genentech is what we would call a reliable manufacturer. The drugs should work identically at the cellular level. Clinical trials of the approved drug will already have established the standard for comparison. You would typically start with a similar dosing and treatment frequency. You have a general idea of what the treatment outcomes should be from the approved drug, and at least a guesstimate of the adverse events, what and how often. Also, there has to be nothing else different about the off-label drug that could cause separate problems. And this gets down to the nitty-gritty of manufacturing, including how the product is packaged, shipped, stored, and diluted. And any one of these things could create a tsunami of problems if you simply assume that because two drugs work the same way, they'll do the same thing and have similar adverse events. And if you're wrong, you may be cataclysmically wrong. But off-label is different from going radically no-label. When you go radically no-label, you abandon safety. A no-label drug has not been approved by the FDA for anything. How do you become a no-label drug? Well, one way is that you're a drug and you fail human clinical trials. You're too unsafe, fail the phase 1, not effective enough, fail the phase 2. Well, this kind of drug is not going to be marketed because the manufacturer is not insane. So you can't buy it anyway, and if you can't buy it because it's not marketed, that's actually not a drug. How about option 2? Biological eye drops, which have never had human clinical trials, but these you can buy. And when you do buy them and use them, you are radically no-label, and you have abandoned safety. What manufacturers will tell you is that biological eye drops are just like autologous serum tears, but more convenient. Let's look at manufacturer number 2's formula. You start with half a cc of amniotic fluid. You don't really know what's in it, but you don't really know what's in your own blood serum either. So I'll let this issue pass for now. But it's not really just like autologous serum tears, because then you add 5 cc's of vehicle, and this is a 9% solution. AST usually starts at 20% and goes up from there. So ask yourself, how much did I just pay for a 9% solution? And for those of you objecting to the math, the way you do this calculation is you take the volume of the amniotic fluid and divide it by the total volume. So it's 0.5 divided by 5.5, not 0.5 divided by 5. It's also not autologous. Autologous means you donate it to yourself. So for you, AST are fresh, frozen, and yours. Your blood means your germs. Placentas and amniotic fluid from strangers means their germs. And also, if you're using a BED with no preservatives, room temperature storage, and a long open bottle time, your germs are breeding inside that bottle and then you drip them on your eyes. Here's the usual counter-argument. I can hear it coming at me from all directions. My doctor recommends BED to lots of patients and hasn't seen any problems. Well, first of all, your doctor might think they're regulated like autologous serum tears. And if you knew they weren't, he might not be so keen. And by the way, if you would like to know why your doctor might be so keen on BED, see Part 2 of Placentas from Strangers. And hey, if it's so safe, why does the package insert say this? Current technologies may not preclude the transmission of disease. Let's think about it. Manufacturer number 2 felt the need to put this warning on their tiny, inadequate package insert. And has your doctor read that package insert? Not unless they ordered up their own bottle, fished the tiny insert out, put their strongest reading glasses on, and read the package insert thoughtfully and critically. Maybe this is what you're thinking in your heart. I'll abandon safety for hope. Let's consider this with scenario 1. Your doctor recommends Azasite for blepharitis and says it's worth a try. It helps some people. It's hard to tell which patients it will and won't help until you've tried it and it has or hasn't helped. You have no allergies to azithromycin or any similar antibiotics. You take it, and you are one of the patients who develops an acute allergic reaction, which your doctor manages correctly. Unfortunately, your dry eye symptoms are permanently worse. Is the doctor upset at himself in this situation? The level of upset would be pretty low. How upset are you for trying it? Only you can answer that. How upset are you with your doctor? Hopefully, not too much. The drop was not overpromised, and the likelihood of an acute allergic reaction was very low, but not unknown. How about a very different scenario? Your doctor recommends biological eye drops because you have a hard time getting autologous serum tears. While you're using those drops, you develop repeated episodes of bacterial conjunctivitis. Your doctor doesn't understand why this is happening, but treats you appropriately. And finally, someone wises up that this problem started during month 3 of your current unpreserved BED bottle, which became contaminated with your own bacteria. Unfortunately, the exposure to antibiotic preservatives makes your dry eye permanently worse. Your doctor never considered until you came along the risks associated with no preservatives, convenient room temperature storage, discard after 90 warm days, and the Frankenstein bottle. This is a bottle with a regular dropper, not a multi-dose preservative-free dropper, and no preservatives. Is the doctor upset at himself? Not sure. Are you upset at yourself? Only you can answer that. How upset are you at your doctor? Once again, only you can answer that. But please keep this in mind. A complication might happen rarely, but if it happens to you, it's 100% of you. Therefore, before you try a particular no-label treatment, pretend you have a complication and ask yourself how you would answer these questions. It's really one of the best ways to seriously consider the wisdom of using a no-label drug or other treatment. So be smart, not radical. Hold out for a real drug label. I hope this information has been of value to you in assessing whether or not you wish to attempt biological eye drops as a treatment for your dry eye disease or other ocular surface disease. Thank you for listening.